Hello, my name is Collie Shaw, and I'm an internal medicine resident here in Searcy, Arkansas. I would like to present to you a curious case of a high anion gap metabolic acidosis following a sodium thiosulfate infusion. My co-authors are also Doctors Poyser, Pham, Mock, and Martin. Just as an introduction, sodium thiosulfate is an infusion and mainstay treatment of a condition called calciphylaxis. This is where skin becomes necrotic because of calcium and phosphorus depositing there, leading to avascularization and a lot of pain and morbidity for patients suffering from it. Although calciphylaxis is rare, it's usually seen in end-stage renal disease patients who are undergoing dialysis. This is no different for our gentleman who presented to the emergency department with worsening shortness of breath and dizziness, who had experienced his first infusion of sodium thiosulfate 3 days prior to presentation. Shortly after presenting to the emergency department, he was found to become progressively hemodynamically unstable, meaning that he became extremely hypotensive, which was even resistant to septic levels of adequate fluid resuscitation. There was this concern that he was becoming septic, and he was transferred to the medical critical care unit because of his resistant hypotension. He required large amounts of Levophed to keep his blood pressure in a stable way, and he had to become intubated because he could no longer protect his airway. His initial presentation, he was breathing very quickly, very deeply, and was not compensating well. His initial ABG, as he was en route to the MICU, found that his pH was 7.07 with a normal appearing PCO2 of 30. His bicarb, though, was 10. Out of concern for sepsis, other labs were drawn, including a lactic acid, which was curiously only 0.4. His anion gap, however, was 45, and his creatinine was elevated at 13.2. His white count was also elevated at 17, and imaging was performed to try to find a source of infection, and there was no evidence of infection in the entire pan-scan CT that was ordered on him. There was also no abscesses to explain his elevated white count and hypotension. He was still treated with empiric antibiotics, but we were still looking for answers as to why he was having this resistant hypotension and why he was so hemodynamically unstable. His nephrologist and the outpatient also worked with us in the critical care unit, luckily enough, and he theorized that he was having a reaction to a sodium thiosulfate infusion. His progressively worsening shortness of breath started shortly after the infusion, and he had heard about rare cases of extreme acidosis in these patients. Because of our quick case review, we discovered that this was indeed the case, and we started treating him in addition to his pressor support with bicarbonate infusions over 4 days. Over 4 days, his anion gap improved. It went down to 15 from 45 very slowly over 4 to 5 days, and his pH improved in the same amount of time from 7 to a normal range of 7.3. He was able to be weaned from pressor support and was extubated on day 3 of his hospitalization, but he still required BiPAP ventilation to help with his respiratory distress. Even still, he was extubated, put on the floor, and his pH and anion gap pretty much normalized, and he was discharged with a plan to start another trial of sodium thiosulfate. Although he had had this reaction, his nephrologist wanted to trial him at a slower rate because he was still suffering from major amounts of calciphylaxis, which was causing huge amounts of pain and morbidity for the patient. Here you can see a picture of the sodium thiosulfate in its chemical structure, and it's an old medication that was introduced in the 30s to treat cyanide poisoning. Now we use it for calciphylaxis as well as cisplatin-related ototoxicity. Because of its chemical structure here and its chemical bonding, it rapidly creates metabolites from minerals found in the bloodstream and creates organic acids in the process. As a discussion, however, with this patient, calciphylaxis is still a challenging, even life-threatening sequelae of end-stage renal disease. It causes huge amounts of pain, lower quality of life, as well as the other comorbid diseases that these patients deal with. As you can see, it starts as a mild skin necrosis and can bloom into this full ulceration and nearly charring of the skin, as you can see in the second picture. In a subset of patients who take sodium thiosulfate, it is theorized that there's a genetic inability to clear the metabolites, these organic acids that are built up through the infusion, which leads to kidney dysfunction, respiratory compromise, and the acidosis that was seen even in this patient here. With this in mind, it's ideal when you're starting sodium thiosulfate on patients to keep them under very close monitoring, to watch them even perhaps daily for the first few days, as it takes a while for these acids to build up. And if he or she does develop a reaction such as the one with our patient here, prompt critical care is crucial for good outcomes. It took large amounts of support to keep this patient hemodynamically stable throughout the 5 days. And that is our proposal, is that with each new initiation of this infusion, that much closer eye is kept on these patients, and that a low threshold to transfer to the hospital is key in case that they become unstable. And I appreciate you listening to my talk about this very neat reaction. My references are listed below. This is Kali Shaw, and thank you for your time.